Okay, well, we're at the start of our session, so I'll just kick us off and say thanks everyone for joining this Flash Talk session. We have a series of 8 really fantastic talks. I'm really excited for it. The theme of our session is using digital mental health tools to regulate emotions and reduce unhealthy behaviors. So we'll start out with Eric Kuhn here from the National Center for PTSD. Each of the presenters will have about 8 minutes, and that's including questions. So I'll keep track of the timing, but I will turn it over to Eric. So Eric, the floor is yours.
Thank you, Stephen. So I'm going to be sharing some findings, and they're very, very, very preliminary. We just scrambled to kind of get some quick analyses done for this talk. So definitely not ready yet for citations, but hopefully you'll find them intriguing as I do. And so this is a presentation that includes my co-PI on this project, Dr. Kyle Possemato, and the rest of our team. Just business keeping here. I have no commercial relationships to disclose, and as a VA U.S. government employee, I have to say that the contents of this presentation do not represent the views of the U.S. Department of Veterans Affairs or the U.S. government. And our funder was VA HSR&D on IAR merit back in 2015, and Kyle Possemato and I are the PIs on this project. So we launched PTSD Coach back in 2011, and it since has been downloaded about 1 million times worldwide, and there's versions of it that have been created by other countries, which is really exciting. But you can see here it has your typical components, the psychoeducation, it has symptom self-monitoring, it also has interactive CBT-based and mindfulness-based tools. And it's also, what's cool, has recently been translated, and it's available in Spanish, so you can toggle in the app to get it to be rendered in Spanish. So very early on, one of the original use cases that we envisioned for PTSD Coach was using it in primary care settings, because we know that PTSD is highly prevalent in primary care patients. In fact, in veterans, it's about 12%. And if we think about the VA population of being about 7 million veterans, that's a lot of veterans showing up in primary care with PTSD. Unfortunately, we don't have brief evidence-based treatments for PTSD like we do for depression, anxiety, hazardous drinking. And we know that these patients are really reluctant to go to specialty mental health care. So we designed, using the CFER model, we designed an 8-week protocol that includes 4 30-minute sessions that was optimized for primary care. So thinking ahead, like this is intentionally being designed for, if effective, the VA primary care setting or other primary care settings. We pilot tested that protocol in a small-scale randomized control trial with 20 veterans. And what we found relative to PTSD Coach, kind of given with a 10-minute intro, is that over 8 weeks, it looked like PTSD Coach with clinician support was more effective than self-management alone, although self-management alone showed a moderate effect size for improvement in PTSD symptoms. We also saw in that trial that clinically significant change was a lot higher, meaning 10 points on the PCL4, clinician supported than self-managed PTSD Coach. And this should not be a surprise when you add clinicians. But we also saw, which was really cool, that the rate of referral, the acceptance of a referral to mental health care was dramatically improved, as was actually attending mental health treatment, because oftentimes they'll accept the referral but never show up. So we have this large scale pragmatic effectiveness trial to investigate the impact of PTSD. So the impact of PTSD Coach on the severity of PTSD, engagement in mental health care, and satisfaction with this particular treatment. And we've enrolled and randomized 234 patients, and retention was really great. We had 91% complete the 8-week. In terms of PTSD, it was kind of moderate, what we might see in VA primary care, with PCL scores around 50. The average age was about 50, and 10% were women, reflective of the VA population, and 35% were non-white. Unfortunately, we didn't see any real differences between the two conditions in terms of, and we were comparing it to primary care mental health integration treatment as usual. We did not see a change. We did not see significant differences in improvement between the two conditions. On the clinician administered PTSD scale, What we are seeing is differences in improvements based on the PCL, the patient-reported outcomes, which is exciting. And then we can see that improvement seems to be maintained over time. In terms of clinically significant change, we are seeing that PTSD coach with clinician support is better than treatment as usual. It's also the number of folks who are below the cut point for PTSD is also higher for those in PTSD coach versus treatment as usual. And it looks like there's potentially something here in terms of the number who actually attend to mental health visits. And this is what we had operationalized as engagement in care. So we're very excited about these preliminary findings. And if they hold up, we're hopeful that PTSD coach with clinician support will be used at scale in VA, PC, and possibly beyond.
Awesome, thanks. We have time for about 1 or 2 questions. I also noted for people, feel free to put questions in chat. I imagine, we have limited time between the talks, but I imagine the authors would be willing to answer questions in the chat after their talk. Eric, I'm actually really interested, as you mentioned, these apps have been downloaded a lot, and these trials, are fairly, small in comparison in some ways, and curious about your thoughts about sort of relative advantages of, trying to think about rigorous clinical trials versus real world evidence in the case of building up an evidence base for the apps that you all have.
Yeah, so it's a great question. So, we are doing a lot of these in the wild studies. So we're trying to, we have a fully de-identified anonymous usage data from every download. And so we can go in and see if folks are actually benefiting. We can't collect any personal information or anything like that, but we do have a number. And recently, Haijing Hollenbeck has published something on PTSD Coach 3.1. And so we think we're seeing some signals from a public health perspective that these apps could be having an impact, but they also suffer from all the same kind of issues with other apps out there, right? Where we have huge attrition, and maybe some of that is just what's to be expected, and actually folks who are not really needing the use of the app. But it seems like if we can get it out to enough people, there's a substantial minority of folks who are benefiting from these apps. But we do think that a lot of the value is going to be when we bring them into the healthcare system, especially a system like VA, where we can offer a menu of potential treatment options to folks who maybe are not ready or not able to fully engage in care at that moment that they're offered it.
Awesome. Well, thanks so much. We'll move over to our next presenter, who is Gemma Sharp. Gemma will be presenting on a real-world evaluation of an eating disorder-focused chatbot called KIT.
Thank you so much, Stephen. Can you all hear me okay? Great, I'll just share my slides. Just one moment, sorry everyone. Everyone can see the slides?
Looks great.
Brilliant. Thank you very much. Thank you, Stephen, for that introduction. It's an absolute pleasure to be with you today to present on KIT. Just like Eric, I'll say that my findings are a little bit more preliminary as well. I also wanted to say greetings from Melbourne in Australia. It's 3:30 a.m. here, so I do apologise if I accidentally fall asleep in this talk. Feel free to just wake me up by putting things in the chat. So as I said, I'm from Melbourne, Monash University in particular, and my Twitter handle is on the bottom of the slide at Gemma Sharp 11. Feel free to tweet along during this presentation if you wish. So some really quick background information on eating disorders. They're highly prevalent around the world, more than 1 million people in Australia, in my home country. But unfortunately, less than 1 in 4 people ever seek support for these issues. And negative body image is one of the strongest risk factors for development of an eating disorder, and about 50% of people in Australia experience this. So clearly intervening early and preventing is really crucial. Something that's also very popular is social media. And while social media can be really fun and exciting, unfortunately, it can also have really negative impacts on our body image and mental health. And in September 2021, with the leaked findings from Facebook, we know that they also know that too. So body image is a real issue on social media. And that's why it's considered the key battleground for body image interventions. So what kind of intervention, I hear you ask? Well, why not a chatbot? And I know everyone here would know it, but just in case, it's a computer program that uses artificial intelligence to have human-like conversations. And the evidence is really growing in the field of mental health for chatbots. Particularly young people can find it easier to speak anonymously with a non-human on sensitive issues such as body image and eating behaviours. And when we started this project back in 2018, there were no publicly available chatbots that specifically focused on body image and eating disorder support. So I'd like to introduce you to Kit. Hi, Kit. So we can see on the left-hand side, there's Kit's character. And on the right-hand side of the slide, it's a screen grab of Kit running in Facebook Messenger. So we can see from the right-hand side, Kit is a text-based chatbot purely and is rule-based, and people communicate with Kit via buttons. So we can see there, Kit has asked, what can I help you with today from these options? And you can choose learn the facts, try coping skills, etc. So in terms of Kit's dialogue, Kit's capable of chatting with two different types of audiences. There's the help for me side and people seeking help for another. And Kit delivers two different types of evidence-based interventions, psychoeducation, which Kit calls learn the facts, or try coping skills, in particular CBT-based and mindfulness-based skills. And I won't go into all of the design elements of Kit as we published them in JMIR in 2021. So please feel free to check out this paper if you're interested. But suffice to say, it was an extensive co-design process with people with a lived experience. But what about our real-world evaluation of pilot Kit? Well, we launched Kit in November 2020, which was very much in the depths of the COVID-19 pandemic.
Working on.
I'll keep going. Did anyone else hear that? So we launched Kit in November 2020. Kit was running through two different channels. So there was Kit running on a website as well as Kit running through Facebook Messenger. And we collected data by two different means. So analytics, the back end, as well as some very brief surveys within Kit's chat. In terms of the analytics, we found Kit was really highly used, over 20,000 unique users in under 12 months. And for Australia's population, that's very high. Most people were seeking help for themselves. And the most common conversations Kit had were those micro interventions. So the CBT and the mindfulness-based skills. And the average conversation length was just under a minute and a half. So that goes to show that people were actually having a bit more in-depth conversations rather than something quite superficial. In terms of the people who were using Kit, we were able to obtain this from our brief conversational surveys. It was predominantly females in their adolescent and mid and early 20s, I should say. And really heartening for us was that about 1 in 5 identified as LGBTIQA+ or culturally and linguistically diverse. And that's really great because these groups often do not seek support for body image concerns and eating issues. And certainly that's reflective of how we co-designed Kit in those early stages to be very representative. We also had a great satisfaction rate of 70%, which is good for a chatbot. And what was also heartening was that those micro interventions that Kit taught did result in statistically significant improvements in the user's body image as well as mood. We also collected some short qualitative responses in those surveys, and users generally had a very positive experience with Kit. But the biggest criticism was that they wanted Kit to have more sophisticated conversational AI, be more engaging. So they wanted conversations beyond those button prompts. So to conclude, it looks like from our interim results that KIT is highly used and by diverse users, and the micro skills that KIT teaches are effective. But really, this is just the beginning. So we have a second generation chatbot in testing that has much more advanced AI, more capable of answering those free text questions. And we're also planning for international dissemination later this year beyond an Australian audience. I'd just like to acknowledge my great collaborators there on the slide. I should have also said up front, I had nothing to declare, so ticking that box there. And of course, if you have any queries for me, I would love to hear from you. All my contact details are there on the slide. And I thank you all very much for listening to my talk.
Fantastic. Awesome. Thanks for the great talk, Gemma. In interest of time, we're actually going to move on to our next presenter, which is Heather Quirk. But if you have questions for Gemma, please put them in the chat. Or as she graciously mentioned, feel free to email her or contact her through social media. So next up, we have Heather Quirk, who will be presenting a qualitative exploration of college students' experiences using a culturally adapted mobile application to improve self-care.
Okay, hi everyone. Great to see you all here. Everyone hear and see? Good, okay, great. So yes, the study is exploring students' experiences with culturally adapted mobile applications. So just some background for this, culturally adapted interventions, as you likely all know, are just interventions that have been modified from their original form to more specifically target certain communities, certain issues, certain cultures, and have been supported as an effective approach for in-person, more traditional face-to-face treatment for various psychological disorders. However, there's been very little research done on mental health apps in general, and specifically on culturally adapted mental health apps. And so this study aimed to just first get some qualitative feedback from students who, might, as far as their generation goes, might tend to be the more frequent users of apps and that such thing anyway. So our question was, and sorry, my Zoom is in the way, there we go. What do students experience when choosing and using a culturally adapted mobile mental health application to improve self-care? This data was collected from 265 students that were enrolled in a psychopathology class. They went through a 3-week project on self-care, during which they downloaded an app from a list of 6 recommended apps to use for self-care. And similarly to Gemma's, this was right in fall of 2020, spring of 2021, so really right in the middle of the pandemic. 14 students of that 265 chose the app called The Safe Place, which was the only culturally adapted app on the list. They answered several questions about their experience, and we used Braun and Clark's 6-step analysis procedure to code the data. So a little about The Safe Place. Is it a minority mental health app that is designed by and for the Black community? It involves several tools, including awareness, support groups, as well as more specific tools for coping with police violence, the pandemic, et cetera, in a kind of culturally adapted and specific way. So as far as the themes that we came across in this, there are several. First, students across the board expressed several different reasons for choosing mental health apps, including, the resources that were included, or the aesthetics, or what maybe condition they targeted most. But all the students that chose the Safe Place app did specifically note that they chose it because it was tailored to their community. So as you can see, I feel safer and more comfortable choosing this app because I feel like the people in this community would understand where I'm coming from more than anyone else can. Secondly, participants did report the app was easy to use and helpful. Again, a lot of that was attributed to its specificity to their community and to the issues that they encounter. As you can see in the left-hand quote, for example, there's a section under self-care tips titled "Self-Care During Police Brutality with Great Suggestions." So students really valued, the more specific tips and content for them in this type of app. Participants did report that app usage improved their overall feelings. If you see the bottom right, I love this quote: "Without the Safe Place app, I do believe that I would still be drowning in stress from the various things that might come up during a typical day. I now know how to recognize those moments and have breathing techniques to help me," which is just Wonderful. Participants also reported that their knowledge expanded just in general education about mental health as well as self-care practices. As you can see, bottom left, personally, it made me realize how important self-care is. Self-care is critical in helping you grow as a person and teaching you how to truly love yourself. Finally, as far as the themes that we collected around continuation of like app use and self-care, there was definitely mixed reviews about continuation of app use. However, all users did indicate that they would continue to prioritize and recommend self-care as a result of this experience. And as you can see, these quotes kind of also show the two different sides and kind of why people mostly said they would choose to use or not use the app for self-care. But again, most did say that they would continue to do self-care practices in general. I just love this quote. I think it captures a lot of all of the themes. Specifically, the app has opened my eyes to how everything, including stress and mental health, is different and much more serious for African Americans. And as you can see at the end, this eye opener makes me want to spend my time on this earth happy, and being happy requires me to prioritize myself, which comes back to self-care for this individual. So as far as implications, as a result of looking at this specific set of users of this app, we can see that culturally adapted apps do show promise as a supplement to therapy or as a standalone support, and does warrant further collaboration and study. There's very little published on culturally adapted mental health apps, and very few apps out there in general to even study. So warrants a lot of focus in both of those areas. App developers and therapists should definitely consider some of these findings that we saw as far as needing, fresh, relevant content specific to, the particular community or culture when building these apps out. And then finally, I'll just touch on the fact that this was incorporated into a classroom, and many students did indicate, kind of as part of that education theme, that they didn't know about apps like this before, that anything like this existed. So just kind of some support for maybe incorporating these sort of practices in familiar environments to students, like classrooms and others, as a way to expose them to interventions that they may not have known existed. This is our land acknowledgement for where we collected our research. And thank you to all of the people that made this happen.
Awesome. We have probably time for a question for Heather, if anyone has one. Feel free to raise your hand, unmute. I have a question, Heather. How did you guys choose the apps that you used, and what were some of the other apps that were presented to students?
Yeah, that's a great question. So the 6 were PTSD Coach, IntelliCare, Mood Tools, Fear Tools, The Safe Place, and Headspace. These were selected for a few different reasons. All of them either are free or have a free trial. So students, could have easy access to them for those few weeks, as others do have costs associated. Secondly, most of them did either have tools or education in them that had a basis in CBT or other supported methodologies of therapy. And then finally, we kind of just tried to pick ones that had various focuses. For example, Mood Tools is focused more on depression, Headspace is a little more general, The Safe Place is culturally adapted, PTSD Coach, as we heard earlier, is more, targeted at, potential PTSD, VA type things. And then IntelliCare is one that's just sort of super broad, and you can kind of go a lot of different directions with. So just sort of tried to offer some variety in what students could pick from to hopefully show them something that was relevant to them.
Fantastic. Well, thank you for a great presentation. That was great. Next up, we'll have Nikki Theofanopoulou. Sorry if I butchered the last name there.
No, that was very good. Thank you.
Presenting on facilitating supportive parental emotion socialization practices through a situated technology-enabled intervention for child emotion regulation.
Thank you. Hi, everyone. It's great to be here with you today. So I'm Nikki, I'm a second-year PhD student at King's College London, and today I will present our work, which sits at the intersection of human-computer interaction, parenting, and mental health. Oops, sorry. So the wider motivation of this work is the importance of emotion regulation, a fundamental life skill with long-term impacts on positive adjustment, academic performance, and both physical and mental health, with research showing that emotion regulation deficits underpin a range of mental health issues such as depression, anxiety, and self-harm, among others. So we know emotion regulation is really important, and we know that those skills are in large part shaped during early childhood through a process known as parental emotion socialization, which put simply means that parents help children understand, regulate, and appropriately express emotions through the way they react to their emotions, how they discuss or don't discuss emotions, and how they themselves express emotions. Despite the importance of those practices for children's lifelong well-being, only few parenting interventions started them explicitly, and the few that do are time and resource intensive. They lack scalable delivery approaches, as they usually require parents to attend multiple professional-led sessions over a number of weeks, and also typically struggle with transferring learnings from training sessions to daily lives, to the situations when parents actually have to apply what they're being taught. And so while technology has the potential to address these challenges, only limited work has looked into how this could be achieved. So we started unpacking this space by using Purble, a technology-enabled intervention in the form of a smart toy, which was designed specifically to support children's emotion regulation efforts in the moment. So Purble has emerged from prior HCI research and has now been turned into a commercial product by a US nonprofit. And the way it works in a nutshell is that its heart starts racing, and as a child comforts and pets it, its heartbeat gets slower until it eventually becomes a purr, helping the child calm down or relax in the process. While our previous research has shown promising results with regard to offering in-the-moment support to children, we hadn't specifically looked at if and how it could also facilitate additional parent-child interactions around emotions, since it's basically placed into families' homes. So to start exploring this, in phase one of this work, which is the focus of this talk, we interviewed 29 parents of children aged at 10 years old who had had the smart toy for at least a month. And while I won't be talking about the next phase today, the aims there were to explore how the smart toy could be expanded and linked with positive emotion-related parenting practices, and what additional design work would be needed to facilitate this. In the interest of time, I'll only focus on the most interesting findings from phase one, and you can refer to our paper for the full findings if you want to. So the majority of children who took part in the study interacted with the smart toy, with their parents reporting that it had impacted their emotion regulation skills and practices in a positive way. But what was interesting was that for 10 out of the 29 families, the smart toy appeared to naturally elicit additional parent-child interactions, with parents talking about how having it around had facilitated discussions around emotions in various interesting ways. For example, by helping the child reach a calmer state in moments of heightened emotion, it allowed parents to then initiate discussions about the feelings and reasons behind the child's behavior. Or some parents found that it just naturally brought up the topic of emotion regulation and served as a prompt for them to initiate related discussions in a casual and non-intimidating way. Again, almost a third of our participants reported that the smart toy also impacted the dynamics within their family in some way, mainly by leading to less disruption and conflict during moments when the child would be asked to calm down. So in terms of the toy's impact on parents' practice around emotions, it seems that for the 10 families which reported wider changes, there were shifts in the ways parents reacted to and discussed emotions, which shows that something interesting appears to be happening around the smart toy in terms of shifting behaviors within some families without having to explicitly tell people what to do. But for most participating families, the toy alone was not enough to bring about such changes. And our interview data point to several challenges with regards to parents' engagement and involvement, with maybe the most important one that we hope to tackle next being the lack of confidence or knowledge needed to scaffold children's learning around their emotional experiences when situations would come up. So what we will be exploring next with parents and parenting intervention experts is how we can blend the more explicit cognitive skills building that happens in traditional parenting programs with the more bottom-up organic interactions around emotions that we see can happen around verbal when it's introduced within families' daily lives. So thank you for listening. If you want to read our full paper, you can scan the QR code, and please feel free to get in touch with us via email or Twitter. Thank you.
Nikki, we have time for at least one question. There was a question in the chat. Did you educate the parents on emotional socialization when you provided the toy?
There was nothing really provided to parents. There was a little card with a simple background saying that verbal has emerged out of research, and that they could, for example, use it when their children would need to calm down to help them regulate their emotions, but there was nothing else. So that was what we found interesting, that for some of the families, it just seemed to naturally facilitate some interesting interactions.
Fantastic. Well, thank you so much. And as Nikki mentioned, there was a full paper that was presented at the most recent CHI conference. So please do check out the paper and contact Nikki if you're interested in learning more about Purble, which is the cutest smart toy I've ever seen in my life. Next up, we have Heather Nunsk, who will be presenting on the Keep Calm app, an mHealth platform for teachers of children on the autism spectrum to support emotion regulation.
Hi, Stephen. Thank you for that. Thanks, everyone. That was a hard act to follow, Nikki. That is such a cool research program. I'd love to work with using the parable in my research. Can everyone hear me okay?
Sound great?
Yeah, okay, let me just share my screen. Here we go. Just sharing a portion of my screen so I can see my notes. Here we go. Perfect. Okay, so yes, I'm going to be talking about the Keep Calm app. This is an app that we have created in partnership with our school district. Was actually named by one of the teachers that we're working with. I am an assistant professor at the Penn Center for Mental Health at the University of Pennsylvania. I'm working with a really great team on this project and have a really excellent industry partner. This is a part of my Career Development Award for the National Institutes of Mental Health. So I am halfway through that. The first year was really getting informative data about the Keep Calm app and its use in the school district. And this was really based on our thinking about stress and autism and how it works. So why do we think that stress detection is important for children with autism? Well, children with autism experience high levels of stress induced by dealing with a host of factors that they come across in their everyday life. So changes in routine, sensory overload, social confusion, bullying, sleep difficulties, lots of stresses throughout the day. And teachers often report to us that he seemed to go from 0 to 100 in 2 seconds flat. And so we know that that is not necessarily the case, and that children's stress levels are rising throughout the day, but because of their difficulties with communicating that stress, that the teachers are not noticing that, especially in the context of a very busy, classroom, many other students that they're supporting. So just because you don't see it doesn't mean it's not there. The difficulties with expressing emotion clearly and with more flattened affect is a part of autism. And we know that from prior work that when children are physiologically stressed, they're not necessarily showing those that stress with communication behavior. So what happens for some children is that they express that stress through undesirable ways, through challenging behavior. So we found in previous research that physiological stress actually predicts onset of episodes of challenging behavior. We found that is published in a study in the International Journal of the Biology of Stress. And we also did some background research before developing the QCOM app on the wearables that were currently available. So we wanted to use something that was going to be scalable for our low resource district that we're working with. So we looked at selected heart rate wearables that gave the data in real time. So that was important. Fitbit or other devices like Fitbit, they do give you the data, but not in real time. So we went through and looked at a bunch of different wearables. We had 9 that we tested for typically developing adults, and then we tested them in children. And these are the 2 that we've ended up selecting based on whether they were comfortable. So 85% of children wore these trackers, and they rated them as comfortable on the comfort rating scale. We also found through many different metrics that they were valid and reliable measures of heart rate and for measuring stress. So we used that information, and that helped us to think through what we would do with the QCOM app. So this is the way that it works. So let's say Jose is wearing one of these devices that he finds comfortable. That connects with the QCOM app that I'll show you in a minute. That is then displayed to his teacher, Ms. Johnson. And what Ms. Johnson's been able to do is understand which strategy they can use for Jose that is dependent on data that is inputted into the app, as well as the physiological stress reduction data. So if their stress is reducing after using a particular strategy and returning to baseline within a certain threshold, we had that specific strategy show as a top strategy for Jose. Other data points that it takes into account is whether the teacher says that the strategy has worked previously, and also whether there's any behaviors happening within a time frame after the strategy was implemented. So they can have different strategies for different children in the class. It's very individualized. And as I said, learns the pattern of which is the top strategies based on those data points. Okay, so this is the sort of concept altogether. The child wears one of these devices. The teacher sees which proactive strategies they should use with the child, and then the teams are able to share the best strategies across the people at school and also with the parents at home. We know that the parents' involvement is really important for these kind of behaviors, and so having the parents be involved was a part of the design of the application. This is just a few images of the app to show you what it actually looks like. So at the moment, we're doing some rapid cycle prototyping with teams in the school district in anticipation of the randomized control trial that's coming up. And so again, the different screens. So the first one here shows the stress zone rainbow, where they can see the heart rate of the child throughout the day over time. You get a pop-up notification to say which of the top strategies they should use with that particular child. There's some reporting and daily reports that will show for the teachers and for the parents. This is showing the parent version, which is more of a narrative view, versus the detailed view for the teachers, which has lots of information about the child's behaviors and strategies from that day. And then we link that with resources that they can use the videos and infographics about discrete strategies that they can use to manage the child's challenging behavior. So this talk is not very data heavy. We're still in the process of collecting a lot of the data, but we have found so far that teachers and parents rated the QCOM app as extremely useful for managing students' emotion dysregulation, and they strongly agree that the system could help to prevent challenging behaviors in students. We also found that the app has been rated as usable, feasible, acceptable, and appropriate using both qualitative and quantitative survey methods. So I just want to thank all the team that's been working on this and my funders and community partners. We have put together a website that has more information about the QCOM app and other apps that we're working on in our center. And here's my email if you'd like to get in contact.
Excellent. Thanks so much for the great talk, Heather. In interest of time, we're actually going to move on to our next presenter. But again, if you can put questions in the chat to Heather, I imagine she'll be happy to field them. So our next presenter will be Shilpa Hampel, who will be presenting on usage patterns of cognitive, behavioral, and mindfulness tools in an anger management mobile app.
Yes, thank you so much for having me. Let's see if I can put my interview here. Okay, perfect. Can everyone hear me okay?
You're actually, can you switch the views? We see the notes.
Oh, okay. How do I do that?
There's a little like round arrow there close to the pause button. To the left. Keep going. Do you see the pause button right below that? Nope, nope. Down. Back over where you were before.
Oh, right
there you
here.
go. Oh, no, not the pause button. The arrow. There you go.
Thank you so much, Stephen. Sorry about that. Okay, so hello, everyone. My name is Shilpa Hampel.
It didn't actually switch. Can you just try to click that one more time real fast?
Sure. Does that work?
Huh, no, that's weird.
Really odd.
There we go, that works.
Okay. We'll go ahead with this. I just won't be able to see my notes, which is totally fine. Hi, everyone. My name is Shilpa Hampel. I'm joining today from the National Center for PTSD. And today I actually want to start with an analogy. I'd like you to imagine that you are at a giant restaurant buffet and you notice all types of people there of different ages, races, ethnicities, gender identities. And as you go further into the buffet, you also notice a variety of food. There's an Italian food section, a sushi section, a dessert section. And what you observe is that different people, for different reasons, are gravitating to different areas of the buffet. And we can think about how people use mobile apps in a similar way. So just kind of keep that analogy in mind. And for our study, we looked at usage patterns for users of the Anger and Irritability Management Skills, or AIMS app, which is a free or publicly available app developed by the National Center for PTSD. And more specifically, we wanted to see how users' responses to a 10-item anger quiz, as you can see on the left, which is in this app, how those responses mapped onto usage of 3 different categories of tools: cognitive, behavioral, and mindfulness tools within the app. And so before I talk about what we did, I just want to emphasize the complexity of anger. It can be experienced differently from person to person. There are a variety of symptoms and correlates, and it also disproportionately affects certain populations, such as veterans with PTSD and Native Americans. And we believe that mental health apps can certainly help with these types of issues, and with this app in particular, with the self-management of some of these symptoms related to anger. And so looking at usage patterns can inform how different people are using these apps. So in our study, we looked at an anonymous usage data for Android users from October 2018 to September 2021. And specifically people who completed the anger quiz, so just over 12,000 users at that time. And we saw that users on average endorsed about 5 items, and some items on the quiz were endorsed more than others, and you can't see that there, but the rates varied across the different items. And so this already suggests that people are using the app for a variety of reasons. And so we can think back to our analogy of how people might be at this buffet for different reasons. And so from that sample, we then looked at users who not only completed the quiz, but also used a tool within the app. And so it dropped significantly to around 7,000 users. And so that it's notable to mention that, it's interesting how a lot of people are showing up to this app, are taking the quiz, and a lot of people are not even using the tools. But from there, we wanted to conduct some robust non-parametric analyses to compare the usage of these categories of tools, the cognitive, behavioral, and mindfulness tools, and specifically looking at the number of times these users used the tool between people who did and did not endorse each of these items on the anger quiz. So I'm going to share some of our results. And, so for cognitive tools, first, I just want to say, although the results, as you can see, did not reach the small effect size, our data still can suggest that people who endorsed this first question up here, some people are afraid of my anger or seem to walk on eggshells around me, are more likely to use cognitive tools. For example, thought stopping is one of the tools in the app. And then in contrast, when we look at the behavioral tools, people who endorse these three, highlighted in green, these three items related to arguments with family and friends, experiences of intense anger, trying to hold in the anger, but then exploding. These users are more likely to use the behavioral tools within the app. And this makes sense because with cognitive behavioral therapy, when someone is experiencing anger very intensely, it helps to lower their threshold using behavioral tools first, for example, deep breathing, muscle relaxation, so that they can think more clearly in order to then use cognitive tools. And what about mindfulness tools? So this is where we weren't able to run this analysis with the mindfulness tools, and it's most likely because there just weren't a lot of people who were using the mindfulness tools within this app, which is also really interesting to note. And we're not exactly sure why just yet. So, but with this preliminary study, we can see that, users of this app who completed the quiz and are endorsing a variety of issues are not actually using the tools very frequently or even at all. But if we look really closely, there are some small differences between groups and patterns of usage based on specific anger-related issues that they report. And so for future directions, we certainly want to look more closely at these patterns, identify these patterns, and ask the question, are users who follow some of these expected patterns experiencing more benefits? How can we use this information to kind of predict behavior and predict their health outcomes? And finally, how can we direct users to particular areas of this app or any app that might be more helpful depending on what types of anger and related problems users are dealing with? So that being said, I'll open up the floor for any questions, and feel free to email me if you want to continue the conversation.
We have time for about maybe a question or two. So if anyone has a question, feel free to raise your hand, unmute, or drop it into the chat. I have a question, Shilpa, that just goes to this comment you made about mindfulness tools. And I was curious if there's anything about, the way the tools are presented or navigation or any hypotheses you have about maybe like design features that might lead people towards some of the features versus others.
Yeah, I'm glad you brought that up. That's the conversation we're having at this very moment, is how the app is laid out in the order of these tools. And I think that we can see some patterns there. I think mindfulness tools, if I remember correctly, are kind of closer to the bottom. And also there's a learn feature that users can learn more about the different tools within the app and the strategies for managing their symptoms. And there is a section on behavioral tools. There is a section on cognitive tools, but there is no section on mindfulness tools. So it might not be as clear exactly what the issues these mindfulness tools might be addressing for users of the app, and it might be more clear for the cognitive behavioral. So we have a lot of ideas kind of floating around, but that's certainly the design and layout can push people to different areas of the app, and rates can vary based on that too. Yeah.
Awesome. Well, thank you. Well, thank you for a very nice presentation. I really enjoyed it. So next up, we have Jess Williams, who will be presenting on the feasibility and acceptability of experience sampling methods among LGBTQ+ young people with experiences of self-harm.
Brilliant. Thank you. Can you hear me okay before I start anything else?
Sounds great to me.
Cool. Brilliant. So hi, I'm Jess. I'm a postdoc at King's College London, and as you might be able to see from my slide, I seem to be collecting institutes as I go along. Today I'm going to be talking about the last study of my PhD, which was looking at the feasibility and acceptability of experience sampling methods, or ESM, among LGBTQ young people who have some experiences of self-harm. So self-harm is a really key issue impacting young people. Within that group, LGBTQ youth are particularly vulnerable. It's thought that there's about 30 to 50% more likely for LGBTQ young people to engage in some form of self-harm or suicidal behavior, and that includes thoughts, than cisgender heterosexual peers. So given these really significant disparities, it's crucial to explore the processes which underlie these thoughts and behaviors. And a really useful way to do that in real time is using experience sampling methods, also known as ecological monetary assessment. And typically this involves a series of brief questionnaires multiple times a day for a set amount of time. And it offers in-the-moment responses of experiences, thoughts, moods, and has the added benefit of addressing participant recall bias and enhancing ecological validity. So for this study, I want to see if firstly we could do this with young people who were LGBTQ who had current experiences of harm, and whether they would accept it. So my study was a mixed method design built with 3 phases. This was the baseline assessment, a 7-day experience sampling period, and then followed by a semi-structured interview. And this was co-designed with the LGBTQ advisory group, who were a group of lived experience young people. The participants I were looking for was between the ages of 16 to 25, LGBTQ, living in the UK, registered with a GP, and had current self-harmful thoughts or feelings or behaviours. So to take part in the study, participants needed to download an app onto their phone, through which they would receive 6 alerts over the course of 7 days, and they had 30 minutes to answer each alert. And this took about 2 minutes for them to complete the survey. And the items selected, so here, were based on previous work within my PhD. And these were underlying processes or experiences which has been discussed as highly influential to young people's self-harm. So the final sample that I had was 16 LGBTQ young people, and the average age was 19. 12 of my participants were cisgender and 4 were transgender or gender diverse, and over a third were bisexual, but we had a range of sexualities represented. Over the 2.5 month recruitment period, because that's the only time that I had the app for, 29 young people responded to the call, and then we had 16 who provided valid consent forms, and 100% completed the baseline and the ESM assessment. And then 12 also went on to do the post-ESM interview, which was grand. For participant adherence, each participant received 42 surveys over the course of the 7-day assessment period, which resulted in a possible 672 surveys across the whole sample. The number of responses that we did have was 454, so that was 67.6%. And on average, participants completed about 4 surveys per day. We assessed acceptability through the interviews, and these interviews sort of explored the perceptions of taking part in the ESM study, the challenges and facilitators taking part, and opinions about what we could do better. Briefly, the participants discussed the practicalities of the ESM surveys, the barrier that was the daily timeframes, tended to be that young people don't like waking up early, which is pretty fair, and suggestions that we could do for the future So how we could make these more appropriate to the specific groups. And the first theme that we found, and the key facilitator really to engagement, was that participants had this ability to track their mood over time. And this resulted in participants feeling that they had increased awareness of their experiences and their thoughts and feelings around self-harm. And some used this to not engage with their self-harm. So that was a really interesting finding. So the next steps. Well, firstly, this study showed that it was feasible and acceptable to conduct ESM studies with LGBTQ young people who have current experience of self-harm. And from here in my postdoc, I get to keep continuing this sort of research with LGBTQ young people who are either at risk or currently experiencing self-harm. So later on this year, I will be running the related version of this study at Fully Powered, and this will explore the temporal relationships of the identified stressors in relation to self-harmful thoughts and behaviors within LGBTQ young people. If you heard Nikki's talk earlier, we're in the same group, and I get to run a PERBL study, which is very exciting. This is currently ongoing, and we've shown in student populations that PERBL is really useful for helping anxiety. So I'm seeing whether these effects are seen in minority youth who are at risk of self-harm, and whether similar experiences such as help with emotional regulation are also seen, and how this might relate to self-harm. So that's me.
Awesome. Thanks for the very great talk, Jess. We have a couple minutes for questions. If anyone has questions, feel free to unmute yourself, raise your hand, ask in the chat. Jess, did you learn anything about like the types of questions that were more acceptable or more feasible? Because I feel like this is something that I get challenged with all the time when doing ESMs studies, is like how to pick the right questions and what questions don't bug participants too much. So just any insights you could share on, you know, anything you learned about kind of the types of questions or how to ask things.
Yeah, so as for the items themselves, lots of them came from the ESM repository, and we developed LGBT specific ones. Participants didn't like doing the whole GDA7 and PHQ-9 for anxiety and depression all the time, because they were like, we see this all the time in clinical services, which is completely understandable, seeing as they're a bit longer. But the really interesting thing for me was that lots of the young people were saying, oh, we don't need this question about gender dysphoria because we're cisgender. And then they were also fluctuating on that measure. And some people were like, oh, actually, I think that was something that was bothering me. So while it was unacceptable to ask everyone, there was also this like little subgroup who were like, oh, I haven't thought about that. If you didn't ask me, I would have never recognized it as gender dysphoria. Maybe there's something there for me. So it's been a process of, can we capture that in the following study without bothering those who don't feel it's necessary, while still getting that subgroup who also are like, oh, but it was a little bit.
Awesome. Well, thanks so much. And last up, we have Fred Munch, who will be presenting on a randomized controlled trial of different text messaging interventions to reduce heavy drinking during COVID, and talking about the mechanisms of action in demographic moderators. Fred, if you're talking, you're muted.
Oh, that's okay. Is this better?
Much better.
Wonderful. Okay, well, everyone, thank you, Stephen, and thank you, everyone. Thanks so much for having this conference. You know, I love the focus thus far. I'm going to be chatting a little bit about a study we just finished on using text messaging to reduce heavy drinking. This is the team. And I'm the old guy in the middle there, and grateful to be on this awesome team. The study was funded by NIAAA, and we're just finishing up right now, so papers to come. In terms of a just larger project overview, I'm going to be quick in the interest of time. Our target audience was heavy drinking individuals recruited online who wanted to moderate their alcohol consumption. And the goal was to test different types of text messaging sent over 6 months, and are they differentially helpful in the short term and long term. This was the larger trial to a pilot study with 130 individuals using a similar design that's published that you can take a look at. That was a 3-month study with 5 different groups. And we did assessments from baseline to 12 months, and we did weekly drink tracking mobile assessments as well. In terms of the study conditions, this was both a comparative effectiveness trial and a study using an active control. So drink tracking, we told people that drink tracking is an effective intervention to reduce problem drinking or heavy drinking, and they got weekly mobile assessment, and they also received all the monthly assessments. Then we had tailored only, and that tailored only group gets the drink tracking plus daily text messages, and 50% of those messages were tailored to their baseline assessment. I'll give you a little overview of that. And then tailored adaptive was they got the TO, but they also adaptively tailored the messages based on their goal achievement, whether they met their goals. We offered the opportunity for just-in-time messages, like to type drinking, for example, and get messages. And then we also offered the opportunity for someone who had a moderation goal to begin to also, if they were interested in abstinence during the trial. Some considerations, typically for these studies, particularly in terms of moderated drinking, not in terms of real world application, but definitely in terms of RCTs. They're mostly done in opportunistic settings like hospital systems or colleges. This was pure internet recruitment. One of the important pieces of this was we also, from an RCT perspective, we had no human contact. So the goal was to test a fully remote intervention. Participants were able to contact the RA with questions. Very few did. We have active controls, as I mentioned. Content tailoring. So the content tailoring for the TO group and the TA group, we looked at gender, age, binge drinking versus daily drinking habits, sort of the type of drinker they were. And then we looked at the median and dropped them into either binary yes or no based on that. And they got different messages based on that. And then tailored adaptive messaging. We looked at the change in goals and also the just-in-time interventions. Overall, 4,000 people came in and tried to enroll in the study, and we enrolled about 731. A lot of people were either drinking too much or too little, but there was a lot of also people who just dropped out during the process. So as we make this available to the public, we know that we just want to make it very simple. Text moderate to 55753, fill out the assessment and go. So overall, what we found was all groups did really well. And we saw a linear effect on average drinks per week. And it was a significant effect. And at 1 month, there was certainly intervention effects where the tailored adaptive had the most robust findings. And then what we saw is over time that changed. And even though the active interventions groups did do better and they were significantly better, overall, all groups did quite well. And the tailored adaptive group did no better than the tailored only group, so the tailored at baseline group. And at 12 months, there was no differences between groups. So 6 months after the intervention was pulled. In terms of heavy drinking days, there was less of an effect. All groups did well. There was zero difference between the tailored adaptive and statically tailored groups. So that's important. ST is TO, excuse me, I made that mistake. So in terms of proactive engagement, there was very little proactive engagement. So this is more of when people engage where they're going to type in keywords like drinking, win, heavy. Only 72 out of the 240 participants in the tailored adaptive group texted at least one trigger word in the 6 months. So very few people were using it, and we would send out a reminder. We did it 3 times during the study. It definitely increased the number of people using it, but few people used it. one of the important findings of this was continued messaging. So after the study, we gave people at 12 months, we said to people, do you want to continue messaging for another 6 months? You can start again in terms of the messaging after that 6-month break. 78% wanted to restart the messaging. When we required the need for a keyword and to complete a new assessment, only 7.1% of participants actually signed up. And then when we auto-enrolled them, because we asked them, do you want this? Then we said, we're going to auto-enroll them. Only 75% stayed enrolled and 25% opted out after they had said they wanted to do it. So we know that, well, I'll get into some of the, oh, that was a mistake. Look at that. Okay, so some conclusions. Overall, messaging is an effective public health intervention. This is an automated intervention. There's no human contact, very much like apps. It's a public health intervention. The effect sizes are less robust, but close to in-person intervention. So it's very powerful, these effects. So for those of you that know the moderated drinking literature, these are substantial reductions, and the reductions in heavy drinking in particular can save trillions of dollars in costs with this. The next trial, we're going to do a coach support hybrid care model, supportive accountability model. Although the TA group did better on DT than drink tracking, it wasn't superior to tailored only. And it gets at what is the mechanism here? And is it that simple goal salience, tailored goal salience is really the most important mechanism? So just ensuring, and it's very clear, I want to moderate my drinking, so we're going to send you those messages. And it's very clear, it doesn't necessarily have to adapt, and that might be very unique to drink reduction, and it might not generalize to others, but it's important. And we know that few participants engaged in effortful behavioral tasks, very few. And that includes signing up for more messages. So when we're doing this, a colleague and I have written a paper on effort optimized interventions and highlighting that effort should be thought at the outset, and messaging is great for that. Overall results are similar to the pilot trial, which is encouraging, and we're going to have the intervention available to the world in about 6 months. And that's all. Thank you very much.
Awesome. Thanks so much, Fred. We have time for probably 1 or maybe 2 questions.
Oh, thanks for doing that, Steve.
So I have a question, Fred. So, there's an assumption that, something is better than nothing. And in this case, do we know that? Like, if folks are in that change, like they're ready to do something about moderating their drinking, and we're trying to move away from wait lists, and would you expect that just kind of that they're ready to change, and that this is kind of like some kind of a commitment that they're going to change? They enrolled in a study, and that you might see another column that might be somewhere in between, or maybe close to what the effects were for this intervention?
Yeah, an ideal way to do this would be to do like some sort of Solomon 4, and really understand, because what we find is that, individuals come into drinking interventions very motivated. Typically, their motivation's high, and what we're trying to do is maintain that. It's not we're increasing motivation, which has been the common misperception, but maintain it. And we think that drink tracking, for example, is a minimal intervention. It's once a week text message to ask how much they're drinking. And so there's 2 things that I didn't present on. One is that the number of adjunctive services people got was a predictor of outcome. So we think of this as maybe more of a curation than an intervention in itself. And even though it's an intervention, which is that people are ready to do this, and we're curating an experience. We sent links to moderation management groups. We sent links to Smart Recovery. And so we're thinking more of this as maybe the narrative that might be doing it, and that though the self-changers in the drink tracking group, if they're ready, they're going to do it themselves. And we gave them that at baseline too. We wanted to make sure to give them that information as well. So that we certainly think that might be part of it.
Really cool. Yeah. And just like how much they want to be poked, during this course. Like, if it's just like you said, the salience of it, like that, oh, I made a moderation goal, whoops, I'm slamming back too many today, maybe I'll put it down.
Yep.
Just keeping that in mind. And do you need to do that every day, or can you do that every week or every month or something? But really cool
We
stuff.
also found that the more severe people were, the more they wanted more messages versus the opposite, highlighting the need for goal salience based on severity. So that might be part of it too.
Awesome. Well, thanks, Fred, for the great talk, and thank you to all of our speakers. I just put a note in the chat, but as a reminder, David Moore is going to be doing a brief wrap-up real fast, just to close out the conference. Also a call for feedback. We have a short survey, so if you have a chance, please join us in the back in the wrap-up room for another 10 minutes, and we'll be closing out the conference. But this was just a really great session with really great speakers. So thanks, everyone.